So now let me introduce our keynote speaker, Peter Piot. Peter is a friend and a colleague. I've known him for more than 20 years. He is someone who understood, we were talking about this coming over here, the importance of global health long before the term was ever used. I first met Peter when I was at the World Health Organization, where he graciously helped me devise the WHO Global Program on AIDS Strategy for tackling the challenge of sexually transmitted diseases in the context of the global pandemic of AIDS. He eventually joined the program as Director of Research and then became the first Executive Director of UNAIDS, the joint United Nations Program on HIV/AIDS, and also was made an Assistant Secretary General of the United Nations, the first time this had been done for a specific disease. Very early in his career, Peter helped discover the Ebola virus in Zaire, and during the 1980s, he helped develop the first international project on AIDS in Africa called Project SIDA, and he's acknowledged as having provided the foundations of our understanding of HIV infection in Africa. Peter went on to be the Professor of Microbiology and Public Health at the Prince Leopold Institute of Tropical Health in Antwerp in his native Belgium. He spent more than a decade as Executive Director of UNAIDS, and during that period, without a doubt, elevated the global response to the AIDS pandemic, which resulted in millions and millions of people in Africa getting access to antiretroviral treatment, which up till then had been impossible, and discoveries in prevention that show great promise of significantly curtailing the spread of HIV infection. Peter has authored 16 books and more than 500 scientific articles. He's received numerous awards for scientific and societal achievement. In recognition of his leadership, he doesn't like when I say this, in the fight against AIDS, Peter was ennobled a baron by King Albert II of Belgium in 1995. Please do not address him as Baron Peter Piot. Peter is now the director of the London School of Hygiene and Tropical Medicine, which many of us feel is the leading public health institution in the world. We are pleased to have a number of collaborators and hope to have more in the future. He serves on our Institute Board of Advisors, where he is providing us very grateful advice. I'm delighted that he was able to cross the Atlantic and join us today. The title of his talk is Global Health 4.0 for 2020. Peter?
Thank you, Mike, and before saying something about you, let me thank you, Victor, for your leadership. It is unusual that someone in your position has this global outlook, and I think your seminal paper on, the academic health system instead of, health is really where you include the global dimension. For me, is one that I've been sending to lots of your colleagues and my colleagues to say, look, just why don't you read this very carefully, because that's how it should be. Everything is being globalized today, and the same thing is happening in higher education, in research, but not yet enough in our concepts, in our approach to health. So thank you for your leadership and also for what you've been trying to push in part of the World Economic Forum, where I've seen that you bring together people who normally would not be thinking through and being active in this field. Even if Mike said that it's not time to pat ourselves on the back, since I have no merit whatsoever in the achievements of the Institute, let me really congratulate you, Mike, and all your colleagues for an incredible job. As you said, we go back about 20 years ago, when you were actually my boss. But I think what's more important, you're the one who convinced me that it would not be the brain death to join WHO, to work with you, because I could, people ask me sometimes about career planning and so on, these talks for students, and I always start with saying, please don't plan your career. That's the first rule. But one thing I had always said to myself, two things. One was that I would never become a bureaucrat, and in any bureaucracy. And so here I got into the United Nations. And two, when I left academia, I said, never again, never back to academia. And here I am again. So never say never. But I'm really very proud to be on the advisory board. Why? Because I think that what the Institute is trying to do and what Duke is trying to do is quite unique in terms of global health. A term indeed which didn't exist when I was young and when some of us were young. But it's quite unique both in terms of the what and the how by pushing the boundaries of what is the practice of global health. It is really anticipating the big problems of our time and also recognizing, as I will illustrate, I hope, with the, just reminds me that I don't know which button to push. I need technical assistance. Thank you. Oh, here. Okay. Oh, yeah. Is that a lot of health and well-being is determined by issues that are absolutely not under the control of the medical profession, that are not in the medical sphere. And I think if we want to get out of this mega crisis that we're all in, regardless which country, regardless whether it's a purely public sector like in my country of adaptation, of the UK, but the National Health Service is a mixed model like in my country of origin in Belgium, or a purely private system. We're all basically engaged in a train wreck, and for many reasons. And one of the reasons that's going to make it worse and accelerating the train wreck, I think, is this pandemic of chronic diseases. And so we need new models, and we need to think also beyond what our classic ways of thinking. So I'm really, proud to be here and to see that you're exploring globally and locally what the innovative solutions are going to be for the future. Because it's clear to me that we can't continue business as usual. Now, Mike asked me to reflect on where we are with global health and what the future may bring us. And predicting the future, of course, is very tricky. But let me say that I believe that we're entering into a new phase. And I call it Global Health 4.0. And looking very briefly back at the history, when I was a student, and I have a diploma in tropical medicine, maybe some of us here. And that was about it when we talked about health elsewhere in the world and so on. And that reflected the whole, a colonial period. We entered then into times of Cold War, and most countries became independent, and the term international health emerged, which I would call 2.0. And that was about health far away, and no connection whatsoever with the local, with the domestic. And then, and this was driven by, I think, the AIDS epidemic and the response, both in terms of activism of young people, political commitment, and so on. And we got into the global health. The term was invented, and I couldn't find back who used it for the first time. And it was also an area, and we're still in there, but I think we're approaching its end, of development aid. And the hallmark of that is PEPFAR, the President's Emergency Plan for AIDS Relief, but also others. Very focused on a few things. And I think now we're entering into a world that is far more multipolar, as President Chirac invented that term, I think, and where true globalization is now entering health, academia, research, education. And that's the phase we're in. Now, that doesn't mean that we've done our job, we've finished our job. I mean, there's still a huge unfinished agenda, which while we are thinking about the future, we shouldn't forget about that. In the year 2000, at the millennium, in the United Nations, since Mike mentioned that, all member states of the United Nations agreed to so-called Millennium Development Goals with a set of targets. Some countries have already achieved these, and that's for 2015, but others have not, and that's the unfinished agenda. Maternal mortality, still depending on whose figures you believe, but 300 to 400,000 women dying from, while giving birth. We heard just at the launch of the Division of Global Health in the Department of Pediatrics that under 5 mortality is still so huge, and it's killing more people than in the total population of North Carolina every year. Nearly all of them perfectly preventable. And then we have the classic or not so classic infectious diseases, AIDS, TB, malaria. Reproductive health and family planning, still a huge agenda with the growing population. Malnutrition, which used to be exclusively undernutrition, but mal means badly, so now we have over and undernutrition. Access to primary health care. We had a major event in Alma Ata, I can't remember the year, but a long time ago. So 76. Health for all by the year 2000, so that's 11 years ago. That was based on the primary health care approach, and it was a total fiasco for reasons we could spend a week on to discuss, and the continuing major health disparities and inequities that Victor alluded to. So, now the world is changing. First of all, the center of the universe is moving back to Asia. And for those who've been ever been, this is a temple of heaven. There is a point where you can stand, and that's the middle, the center of the world. And it was when I a year ago, I became director of the London School of Hygiene, Tropical Medicine. It's one of the points I made in my opening speech for all the staff, and they stared at me back to Asia. I'm always so irritated by the lack of historic perspective. Until about 1800, the majority of the world's economic output came from Asia, not only from China, of course, but and then we had the Industrial Revolution here. But that's so we are in a world of high uncertainty and of tremendous change. We say that a lot, and I hear that a lot, but actually it has always been that way. Let's not forget. There have been very, very rare periods where, for let's say a century, that there was no change and that things were not uncertain. Now, 3 of the 4 top economies by 2020, if not before, will be in Asia. The US will be the 4th one. But Europe, forget it on that sense. No, it's, I mean, as individual countries, the only chance we have, I believe, is if we unite. But that seems to be a bit difficult. Well, at least we haven't had war in Europe. I mean, in the classic wars that we've had since 1945, and that is if the historic merit, to start with, of the European Union. People tend to forget that. Competition for energy, land, water, commodities is going to become more and more fierce because it's a finite type of set of energy and commodities that there are. Climate change, regardless of what one believes, is going to become probably accelerate and more acute. We still have the older problem of demographic growth and aging, and that's compounded by climate change. And then closer to our own business is that R&D and higher education landscape is evolving. I'm convinced that by 2020, we'll see a completely different hit parade of the universities in the world. And again, where the Asian universities will be in the top 20, if not in the top 10. And where also we see far more what today is called, in a bit of a Western-centric way, but reverse innovation. Innovation is innovation, but it's no longer going to come from, from one part of the world. And that's already happening. And then we have growing interdependence at all levels. Probably half of the things that we're wearing and so are made in China. It's also, this is so relevant and so dramatically illustrated by pandemics, that an event at thousands of miles from here can shut down the economy of a country far away, and so on. So all this as a context, and then a new an agenda for global health. Of course, as I said, first point, let's deliver the unfinished agenda. In most cases, it's not a matter of new tools. If there's a need for innovation, it's more for innovation to deliver these tools than in innovating for new tools. But as Mike stressed it, and I think we can't stress it enough, chronic diseases and also mental health are the big issues for the future. But then we have all these points that are affecting directly global health and also what we do about it, how we design strategies, the mega cities. I mean, we had a few years ago the turning point when half of the world's population was living in large cities. The urbanization continues. And in traditional global health, we are concentrating still on rural populations, where there is, of course, the highest inequity and lowest access to services and so on. I'll go quickly over this. But we have the need for delivering new prevention and treatment technologies, the whole issue around health systems, and let's not forget, after all, I'm an infectious disease guy, that you know, pathogens, new pathogens will continue to emerge. This is from the World Economic Forum, which every year publishes the global risk landscape. It's one of the most interesting reports that they publish every year. This is from 2009, but the last year's that came out in January this year basically said the same thing. So I didn't have to make a new slide. But the you know, chronic diseases, according to this is kind of basically an opinion poll among business and political and opinion leaders. Chronic diseases are ranked as one of the top threats and risks in the world for the next 10 years. And at the same category as an asset price collapse, China hard landing, governance gaps, and so on. That's not a small thing. This was not made by people like many of us here, like global health people, or people who are working, make their living out of health. This was by hard-nosed business people who were looking into the future of what is going to affect what we're doing, what the world is going to go through. And so high likelihood and enormously severe. Now, chronic disease, when you look at the issues and what to do about it, at first sight you say, oh, it's very simple. It's like HIV, it's very simple. Don't have unsafe sex, and so very simple. I hear that a lot. Chronic disease also, you know, don't smoke, don't use salt, and don't drink too much, and etc., and exercise. And the reason I'm showing this is that this is particularly about prevention, but except for secondary prevention and the polypill, all this, what you can do, is out of the control, the experience, and so on of the medical profession and of classic health services. In other words, the only way to make a huge difference there is to engage society as a whole and sectors from the businesses who are selling, you know, the food that we eat, and organic farming is not going to feed 7 billion people, so we'll need the food and beverage industry, but how to convince them to sell tasty, I'm after all from Belgium, and affordable and, you know, and healthy foods, and so on. So, and that's a missed opportunity last week or 2 weeks ago in New York at the General Assembly. Because one, it was a declaration without teeth, because there was not one figure in there. I organized the one on AIDS 10 years ago, and we fought very hard to have time-bound targets so that we can hold governments accountable. By 2025 or 2010, we will have done this and so on. And then you can say you didn't do your job. Here, it's all quite intentioned. But the fact that it happened is extremely important, and the train is out of the station. Now, mental health, I'd like to draw your attention, because I know there's a bit of a growing connection here. It's one of the, I think, investments of Duke, of the Global Health Institute, and so it is in our own school. And there are very few in the world. And we have Vikram Patel, who's leading this effort out of India. For me, it's an example of Global Health 4.0, because the agenda is not produced in London. The global agenda is driven now out of India, And what we're doing in London is being inspired from, it's the other way around. But it is really definitely, in terms of global burden of disease, an enormous problem. Now, we're always looking at game changers. And when I was executive director of UNAIDS, I got one of the most frequent letters, if you would do like a Google search and so, the letters that said, "Dear Dr. Piot, if only," this is how the letter starts, you know, you get all this free advice. And then they would say that the one thing you have to do, and that's usually researchers who then push their hobby and so on. And they say that this is the game changer. And that goes from, in my field, oh, if only you circumcise all men, or if only people do this or that, okay. Now, but there have been game changers in global health. And we shouldn't underestimate them. Some of them are medical ones, clearly vaccines in the past, in the field of AIDS, antiretroviral therapy, definitely. But there are game changers that are happening outside the health field. Mobile phones, huge game changer for many things. The social media. First is that smoking was a game changer, a bad one, because game changer can be good or bad. I mean, killing millions of people and continuing to do, and particularly in, you know, when you look at in emerging economies and so on, the growth of smoking is enormous. But now there's also an anti-tobacco movement, which has had enormous impact. And diet changes definitely was also a game changer. So we've been concentrating in our profession, where we come from, with the biomedical background, in developing you know, innovative solutions, technologies, and going to solve it. And I'm a strong believer that these technologies can make a huge difference, no doubt about it. But I think we have underinvested and under-researched and undervalued the fact that we also need innovation of delivery, the systems, and looking beyond the classic health service delivery. Again, thinking of the community, thinking of what we social marketing, what have you. It's not my specialty, but it is something that has not been adopted yet enough by global health. And what I sometimes get then as a reply, and you know, is, oh, it's not for these developing countries. And the predominant feeling of, or implicit, I would say, culture certainly in old public health has been third world technology, third-rate technology for third world countries. Whereas actually, when you look at the history of, let's say, the mobile phone, it's completely different. This is just an example I found it on the website of the African Space Trust for Tanzania, and added to the last part is from myself. But the figures are for electricity, still low coverage countrywide. Generators are a major provider of power, but at very high cost of fuel. Solar panels, we know that can work very occasionally. But you go into any village, you see a bar, and you can follow the latest soccer match from the British football competition on mega screens that I've never seen anywhere in Europe. And that's true whether you go to Rwanda, you go in Uganda. And mobile phone coverage now is about 70 to 80% in Tanzania. And in cities, it's over 90%. And it's with 3G mobile coverage, which is better than when you walk around in Manhattan. Seriously. And so this is defeating classic thinking in development, in international development, where the predominant thinking was a linear one. First you need this, and then you can go to the next stage and so on. No, what's happening is a formidable social change. Same thing, I think, in terms of delivery. We need to think of business. This is a very innovative joint venture between Danone Foods and the Grameen Bank in Bangladesh. And basically, on the one hand, it makes poor farmers give the opportunity to sell their products at good prices without middlemen and so on. And on the other hand, it introduces better nutrition and so on. And everybody gets better from it, and you make even profit. I'm not going to talk about health systems because I don't know much about it. But the global health field is really has exploded. And here just you know, various organizations and academic and not and so on. And the question is now, what does that mean? This is when the map of the world that I found, where you have institutions that have global health in their name. And what do you see? They're all, this North America, Western Europe, only Portugal didn't have one as far as I could see, Japan, Australia, and Peru. That's no institute that I could find in a lower middle income country has that name. Because you can say, okay, that's what, what is about us, but it is more than that. So what I think is that a new paradigm is emerging, while actually the previous one is still information. And that's how often it goes in history. And let me compare what I see as the current model, and forgive me, I don't want to offend anybody, but it's just a bit making for the sake of taxonomy, make it simplify it, 3.0 versus 4.0. 3.0 is the institutes are all based in high-income countries. 4.0, we need worldwide network. The PI is a North American or a European. We have to go to a situation where the PI is far more diverse. We still talk about study sites. That means, okay, a site where we're going to do that work. Actually, what we need is a network of centers of excellence, of partnerships. We're still working mostly, and it's necessary to continue, on largely biomedical and infectious diseases. We're moving, and that's, I think, the Duke is an example of that, to far more multidisciplinary approaches with broad health issues and disparities. The subject of study, often clinical trials, epidemiology, and implementation trials. And I think that we now can go into a full spectrum of translation from discovery to implementation science. And there the train is out of the station in industry, but not yet in global health. And so we should not assume that in a developing country, the fundamental discovery cannot happen, and that, or that we would bring our discovery to somewhere else. And then this is about the end of my talk. I also think that, and this illustrates something that Mike said, in 3.0 we're looking at the individual, that's traditionally for medicine, and at population, that's the traditional object of study of public health. With 4.0 we need to involve the environment also. The environment, we cannot understand the future of health without that today. In education, I also believe we're going to see a revolution. One, we're still mostly in a one-way street where people come to the US and to UK and so on. I think that we're going to see more and more people going to do their PhD. We already see it in Singapore, and it will be good for your CV soon, that you've done your PhD in Shanghai and maybe in Bangalore and whatever. I mean, that's in the pipeline, and we need to be ready for that as institutions in high-income countries. So we'll probably see far more global networks, perhaps something like the Star Alliance or the One World or whatever. There are many models, and I think it's a very important issue to discuss which models, and not every model will be good for every institution. So also, when it comes to capacity building, we should move also and add to the individual training this institutional steam. And then this is, Victor, inspired by you. Still too often, global health is part of international activities of a university. It has to be part of, when it comes to health, of academic health sciences system. And it should not be an afterthought or a secondary thing or something nice to do. It should be in the category of the must to do. And because I think for the future, no institution of higher education that is not dealing with, no, that's a double negative. If you want to be relevant in the world as an institution of higher education, we've got to go global in one way or another. How? There are many ways of doing that. So I think that, Duke, you're in between 3.0 and 4.0. I think in the London School we're also there, but we have quite a bagage, and we've gone through the whole area. But we're also becoming a very multidisciplinary institution and with partnerships. And there are now really good examples of you know, where this new paradigm is emerging. And my final slide is here. This is not going to be easy. And there are many challenges. The first one, as usual, the first one is about power. And who's in control? And who gets the money? Who gets the revenue? Multidisciplinary work, I strongly believe in it, but about everything in the funding system and the review system goes against it. Because even if you have a nice interdisciplinary proposal, it will end up in a monodisciplinary review panel, which will, of course, find all kinds of flaws that, about things that are not from their own discipline. So this is something we have to break through that wall. Also, issues around academic credit and careers. And when after having said all that about capacity building overseas, let's not do that at the expense of our own capacity building in global health at home, because that's equally important. So I'll stop here, and I would say that the key is going to be for global health in order to move is that we keep the triangle together of the science, which we continue to invest, the politics and this broad context, and thirdly, the delivery and the programs, and where we need innovation on all sides. Thank you so much for listening. Yeah, I don't have an answer, Victor, as to most of your questions that you've ever posed to me. But no, but also it's a fundamental question. I actually think that there's a need for several models. One of my the slide was that showing that in the case of AIDS, funding for treatment and prevention of HIV, that there are many countries that can perfectly fund this themselves, but there are some, and it's the most affected ones. Here, this is you see a comparison between AIDS spending needs this is 2030 from the AIDS 2031 work, and versus the GDP per capita, and that countries like Zambia, Mozambique, Uganda, and so on, from the most affected ones, there is no way that they will be able to fund from their own resources this kind of response. On the other hand, even South Africa, Botswana, they should be able to do it. So I think we need to diversify our thinking. That's one thing. Secondly, there is a lot of money in the world, including in countries that we are now working on. And so I think we should go far more to partnerships that are also more in terms of financial terms. And I think like Singapore is an example. And I think there, particularly in Asia, the Middle East, there are opportunities that are can be synergistic if they're done very well. My biggest concern is global health implementation in the poorest countries. And there, I think we will probably need a mixture of what you mentioned, governments, philanthropy, and indeed new models, capital markets, and that's being tried for vaccines, for example. So that's where we need people who are far more familiar with that kind of approach than I am, absolutely. I think that is a key. One element is we should never forget the people and the communities. And I think it's not only, let's say, in countries far away, but also global. In contrast to internet, global, it means here and there. That's global. And so I think we need to think through also for the sustainability of the political commitment, see how can we connect these two far more. And I don't have an answer to it, but it's striking that our school in London, we are surrounded by, in some parts of London, let's call it third world situations. And the same thing is true here. And we've not yet done some mutually beneficial learning that we could do, and I think that's one way. But it's the engagement of people, and it's essential even for introduction of new technologies. I mean, look at immunization or polio is not eradicated for, among other reasons, because if some people think that it's there to sterilize your daughters, I mean, etc. I mean, you need to involve the people, definitely. Good point. Thank you.
Before you step off, Peter, permit me to, what many of you don't know is that Peter is a gardener, and of course, if he's at Duke, we have to give him something to remember us, which resembles a garden. So on behalf of everyone here, we really are grateful. We hope you'll remember this day, and when you look at this beautiful picture of our gardens out here.
Thank you so
very
much, Mike. Thank you.